Hi, my name is Dr. Pranessh Ravi. I'm working as a cornea and phaco-refractive consultant for the Eye Foundation group of hospitals. Today, the topic is about acute viral conjunctivitis. As far as acute viral conjunctivitis is concerned, we have two broad etiologies, DNA and RNA viruses. Among the viral conjunctivitis, adenoviral is the commonest, constituting to 75% of the cases. So let's look at adenovirus in detail. To start with, we have pharyngoconjunctival fever. Serotypes 3, 4, 7 are the commonest. They usually have a triad of pharyngitis, conjunctivitis, and fever. Contrary to EKC, subepithelial infiltration are rarer in this case. Next, coming to epidemic keratoconjunctivitis. This is the severest among the adenovirus. The common serotypes are 8, 19, 37, 53, 54, and 56. It's usually unilateral. Ocular signs and symptoms are more severe compared to pharyngoconjunctival fever. Discussing about the corneal involvement, there are 5 stages. Stage 0, you initially see an epithelial vesicle-like lesion which is hardly perceivable. Stage 1, these lesions coalesce and they involve the deep epithelium. Stage 2, you have superficial punctate keratitis and faint subepithelial infiltration. Stage 3, these infiltrations become more formed, and stage 4, you have a epithelial granularity and the subepithelial opacity is formed. So it is wise to start steroids from stage 3. Subepithelial infiltration is the most commonest complication and it causes significant visual impairment when it involves the central cornea. Let's discuss fact versus fiction in epidemic keratoconjunctivitis. First statement is betadine is intolerable and therefore not a good option for patients, which is fiction. If you're using 5%, it's better to pre-anesthetize the cornea and then apply it and wash off the betadine residue, which is present after a minute of betadine staying in the cul-de-sac. Second statement, betadine prevents formation of subepithelial infiltrates in pseudomembrane. It is a fact. The study conducted by Soleimani et al. Showed that the the patients who were on betadine had a lesser formation of subepithelial infiltration in pseudomembranes. Statement 3, lymph node enlargement are present in majority cases in adenoviral, which is false because not all cases need to be presenting with a lymph node enlargement. Last statement, eyelid swelling is more valuable than follicles in diagnosing adenoviral conjunctivitis. The study conducted by Short et al. Took three clinical signs: the eyelid swelling, patient discomfort, and conjunctival redness, and found that eyelid swelling is a better sign than follicles, indicating PCR diagnosed adenoviral cases. Now, coming to the management in epidemic keratoconjunctivitis, in diagnosis, it's usually clinical. The biomicroscopy can be used to evaluate the cornea to look for any pseudomembranes or subepithelial infiltration. For instance diagnosis, we have a Kudel kind of a test. To start with, we have RPS adeno detector, which was later on superseded by Adeno Plus, which had a sensitivity and specificity of 90 and 96%. Some reports show that Adeno Plus had very low sensitivity, so they suggested to use PCR for final diagnostic confirmation. Viral cultures can also be done. Coming to the treatment part, the basic measures are frequent hand washing, avoiding close contacts and social activities so that you don't spread the virus, and also oral NSAIDs to control the lid inflammation. Symptomatic treatment involves cold compress and lubrication. Topical corticosteroids can be used for severe conjunctivitis, which involves subepithelial infiltration in the central cornea and pseudomembrane formation. And it's wise to not start steroids initially, because if you start steroids initially, you will increase the viral load and increase the morbidity of the disease. Now, here's a video of removing a pseudomembrane. You can use a cotton tip applicator or a forceps, whichever is convenient with you, and you can remove the pseudomembrane. Bleeding while removal is common, so you need not worry about it. Topical povidone iodine with dexamethasone shows promise. There are various studies which have studied this combination and have found that it has reduced the total disease period in patients with epidemic keratoconjunctivitis. In case of persistent subepithelial infiltration, you can switch steroids with cyclosporin. And usually in these cases, the disease will self-limit itself mostly within a period of 1 year in most cases. Talking about other salient points in other DNA and RNA associated acute conjunctivitis, we'll start with Epstein-Barr virus. Is usually associated with infectious mononucleosis, and the disease is self-limiting. In Picorna, you have two types, entero type 70 and Coxsackie A24 variants, and they lead to acute hemorrhagic conjunctivitis. It is shorter and less corneal involving compared to EKC, and it is self-limiting. Paramyxoviruses, usually the conjunctivitis is follicular and occurs as a part of mumps, and no specific treatment is required. These are my references. I would also like to thank the Ocular emergency team of YOSI for giving me this opportunity. Thank you very much.